Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Farden. I'm the chair and organizer of Grand Rounds, and today I'm in my hotel room in London. I guess I'm at the British Thoracic Society winter meeting, hence my formal attire, as I'm about to go and speak at one of the sessions. So I've just snuck out of the Queen Elizabeth Conference Centre back to my hotel so I can introduce Grand Rounds today. I won't be able to stay till the end, and I'll leave things with the team, but I will be able to watch it on YouTube later once I've edited it and uploaded it. As remember, you can watch all the Grand Rounds all the way back to 2015 on the YouTube channel if you're interested. You can, and they're all curated into different playlists. So if you can look back to see what previous talks have been on cancer and the cancer waiting times and the cancer strategy that have been given at Grand Rounds over the last few years. And the team have been with us a number of times over the last few years, in person and virtually, to update us on the cancer board and what their plans are for the future. Today's talk has a slightly concerning title of that cancer is going to is an increasing and severe burden on the healthcare system, and are we ready to cope with this? And of course, cancer touches, I would say, all of us in every service that we work in some way or other. And if it doesn't touch us professionally, it touches us in our personal lives. So cancer is an important topic. It's a priority locally, regionally, and nationally. And our cancer board is working collaboratively across the region to try to improve access to cancer services, to reduce waiting times, and ultimately to improve outcomes. So I'm going to leave you with the team. Mr. Manick here is going to lead things off. He's going to be chair and compere whilst I've gone. Thank you very much indeed for stepping in to give this presentation today, and Tom as well, who's the other Tom, who's going to be speaking a bit later on. If you have any questions, please put them in the chat and then the team can see them, or you can ask questions in the normal manner at the end. I'm sure this will be a fantastic talk. I'm sorry to miss it, but I will catch up later. Thanks very much, everyone. Do please stay muted during the talk, but encourage you to ask questions at the end. Thanks very much.
Thank you very much, Tom. Thanks for the kind introduction.
Okay, so thank you for inviting us. I will run through our recent presentation to the North Cancer Alliance and then to the NHS Tayside Cancer Care Board. We were asked to look at a piece of work around the demand in cancer USC referrals coming into the system and the impact that that was then subsequently having on our diagnostic services. At the round about the same time, so this was earlier this year, April time, Public Health Scotland had released some cancer incidence projections, and we also have access to the public health population projections. So we tied them together to produce a picture looking at overall trends and predictions from 2017 through to 2040. So, oops, there we are. So we will look at a generic 62-day pathway. We'll look at USC referrals and then some capacity planning, style, data, demand, activity, breaches, and performance. And then that will lead on to the impact onto imaging and endoscopy, a little bit on population, a little bit on cancer incidence. So the generic 62-day pathway is very busy, as I'm sure everyone is aware. We have a presentation at GP, a referral into secondary care, and then we're into cycles of clinic attendances, tests, and for cancer patients, as we're discussing, MDT discussions. At the point that a decision is made to treat, and that's the point of consent with the patient, there are 31 days to the first treatment being delivered, and that first treatment might be hormones, chemotherapy, radiotherapy, or surgery. So this bit is 31 days, and the total length of time from when we receive the GP referral to the start of the first treatment is 62 days. So you can see that in this section of the pathway, there's an awful lot going on. It's extremely busy. And notionally, there are 31 days set aside for all of this activity. So it's extremely challenging. One of the things that we are trying to highlight is that the demand from USC referrals received affects a number of services throughout the early part of the pathway before we get down to a confirmed cancer. So the number of cancers that are diagnosed and that we treat per week relative to the number of referrals received is quite small. Broadly speaking, across the different cancer types, it's about 10%. So for every, and the reason why I've used 250 per week and 25 per week is because those are the Tayside numbers. We receive around about 250 USC referrals per week, which then results in around about 25 confirmed diagnoses per week. And this is purely 62-day pathway. So these 250 USC referrals per week need to be worked through. They need to work through our system. And mostly what we're talking about at this left-hand side of the funnel, as we've been calling this infographic, we're working through excluding patients who don't have cancer at each of these steps. So after vetting, excluding a bunch of patients, after first appointment, excluding another cohort, after tests, pathology, and MDT. So the bulk of the work on the cancer pathway, even though there are only 250 confirmed diagnoses per week, the bulk of the work is done on the 250 USC referrals received at vetting, first appointment, and tests to exclude the non-cancers. The next thing we looked at was the pattern of demand, and there was a lot of talk in 21-22 when we saw, so this is this period here, when we saw a shift in the USC referrals received compared to pre-pandemic. And the conversation, the discussion at the time was that this was a bounce back or a recovery from the COVID period where USC demand dropped. Some screening programs were paused, etc. But when we looked at this USC referral demand over a longer period of time, what we found was actually this increase in USC referrals received had been happening for quite some time. There's a chunk taken out of it during COVID, but this period is not a recovery from COVID so much as a continuation of the longer term trend in the increase in demand that had started a number of years before COVID. So we don't think of this in terms of a recovery from COVID. We consider this, we talk about this in terms of a continuation of an increase in demand. So a historic increase in demand. So from July 17 to the second half of 2017, we were receiving 490 USC referrals per month. And at the early part of 24, we were receiving 1,000 USC referrals per month. So over a 7-year period, we've more than doubled the number of USC referrals coming into the system. This slide, apologies, this slide is a bit busy. We've put together a number of metrics on here. So the blue line is the number of 62-day patients that we treat per month. And the bars are the number of 62-day patients who breached the waiting time guarantee. So the number of treatments we delivered was decreasing through to the pandemic and then has been increasing following the pandemic. And we are now treating 20%, 25% more 62-day patients than we were treating back in 2018. So we have uplifted our activity in this patient cohort by 25%. That's a really significant uplift in activity. If we were to see that in other areas like treatment time guarantee and elective surgery and so on, that would be really quite significant story to tell. However, at the same time as that increase in activity, the number of breaches of our waiting time guarantee has increased very substantially. So you can see here in January 24, we had 38 breaches of the waiting time guarantee. During the period 2020 to 2021, we had 38 breaches in total for that 12-month period. So we're now breaching per month what we were breaching in an entire year. So despite the fact that we've uplifted activity by 25%, we are failing the target even more and failing at an increasing rate than pre-pandemic. You can see that the breaches pre-pandemic were averaging around about 20, maybe 25 a month, and we're now up into the 30s per month. So even without the decrease during the pandemic, there's a significant increase in breaches going on, despite the fact that we've uplifted activity. I can see that Jay has joined us again. Do you want me to pause there, Jay? Or
Please, you finish it off. I'll join later. My apologies.
okay, no problem. So this is the consequence on performance. So the number of breaches increasing significantly and our performance therefore decreasing. So from January 21, which seems to be the critical date, our performance has steadily deteriorated. It was down to 57, 58% in May. It's recovered slightly. I think we might be touching into the 60s in the last couple of months. But you can see in the period 2020, we were regularly achieving the 62-day target, and in fact, in 1 month we achieved 100%. So the reduction in performance, the dip in performance is about 66%. And then this chart, which pulls together some of those key measures that we were talking about, you can see that there's a correlation around the early part of 21 where things start to go wrong for us. Demand has increased to quite a bit more than pre-pandemic levels at this point. Performance starts to deteriorate at this point, and the number of breaches per month start to increase at this point. So there's a key level of pressure in the system in the early part of 2021 that then starts to impact on performance. We then looked at what is the impact on our diagnostics, and I wonder if maybe that's a point to pause and hand over to Jay, or what do you think? Yep. Okay. So I'll stop sharing and let you come in, Jay.
Yeah, thank you. Hopefully it works this time. Yeah.
Okay.
Good. I hope everyone can see. Tom, can you confirm?
Yeah, we can.
Yeah.
Yep, that's it. Thanks.
Yes. Okay. Sure. My apologies. I don't know what happened when I started. Everything kind of crashed. So anyway, so this talk has just to give some importance about the cancer and how it is affecting our services, and some data, some photos to show what is the difference between early cancer and late cancers, particularly focusing on surgery. Sometimes it causes some concerns. That's why I'm just giving a heads up warning. And Tom and Mary's data, I think Tom is a lifesaver for this talk at the moment, and because he's a data manager. You can see increasingly for the past, at least for the past few years, every 2 or 3 months, you see some media information about the cancer. Whether it could be a new diagnosis or criticizing the waiting list or focusing on new innovations or changing the way we work or changing the way the cancer services being delivery or the treatments being offered, or like kind of other forms of treatment. So the importance is we need to be a leader, and we need to be in the game on par with what's happening around the world and globally. So if you can see, there are some good news. There is a reduction in the death rate overall for the past 10 years. There is 11% reduction in the cancer mortality. But you can understand there is an aging population in Scotland. So the cancer is on the rise. That's a very simple, clear message. Cancer is on the rise. As Tom said, the referral is also on the rise. It may not be equally like the same number of referrals doesn't extrapolate into the same number of new cancer diagnoses, but both are rising. But that's the clear message we want to pass it. But the question we have is, do we have the diagnostic capacity? Do we have the diagnostic clinics or scans or pathology services to deal with the increasing referrals? These are the questions. The statistics says nearly 35,000 people are diagnosed. 400 people are diagnosed with the cancer in Scotland each year. That is also on the rise. Technically speaking, every hour, for more than 4 people every hour. That's the problem. And also, it's in 2040, it's a 4,200 new cases going to be there. And it's a kind of long-term reliable projection. It's not like a kind of guesswork. Yes, cancer survival has improved, but not at the satisfactory rate. But if you look at this black line, that is it's a mortality curve. Lung cancer is the most commonest cause of death in Scotland, and followed by colorectal cancer. And there is a strong link between the deprived index. Particularly, there is a 74% more increased likely and they die if they come from low socio-economic status. As we talked about, cancer is a burden. How does it affect the workforce? It does. The cancer specialty needs a specialized workforce. It may be from admin, oncologists, surgeons, radiotherapists, nurses, pathologists, radiographers, and even radiologists. So many people, including paramedics and other healthcare professionals who is heavily involved in rehabilitative work, because cancer is not a one snapshot. It's a long, unedited video. It takes time, or unedited movie. Yeah. So cancer can cause mental fatigue for the patients and families, and also the workforce. It's because it's a very stressful environment, and they also deal, the cancer therapists also deal a lot of emotional things that influence the work and the way they work and the way they deliver the cancer. All these cancer treatments are expensive, not cheap, whether it is surgery or radiotherapy or immunotherapy, whatever it is, or rehabilitation, it costs a lot of money. And it has got a significant impact in the hospital and specialist care delivery system. The productivity is most important. Unfortunately, the cancer affects the working class people. So it's even any cancers, they need to take time off. And the family members or caregivers need to take some time off. So it's a financial burden for the family, person, and also to the nation. And caregiver is and the incidence of the cancer, as Tom said, it is increasing, and but it's not increasing on par with the referrals. So there are challenges. As Tom said, we were on the 72%, but now it's dropping down the projections and also the capacity we can deal these patients within 6 to 2 days. So we are doing very well once the cancer is diagnosed, particularly after the diagnosis. 94% receive the first treatment within 31 days, irrespective whether it is surgery or radiotherapy. But the first part of the journey, first 31 days, we are not really doing very well. That relies on more clinics, more investigations and diagnostic services. So And the approximate incidence is 644 new cases per 100,000, which is actually clear increase, at least for the past 3 years. And when you look at this, it's a complex slide, but the most important thing I want to highlight here is there are kind of earlier the person is diagnosed, more likely they have to have a good outcome. So for example, breast cancer, almost 2/3, they are diagnosed at an early stage. But in contrast, lung cancers or colorectal cancers, almost more than half, they diagnosed at a later stage. And the socioeconomic status has got a strong link with certain cancers as well. You can see that clearly most deprived areas, they have a more likely they have adverse reactions to the cancer diagnosis. Could be related to the late diagnosis, or they may present with the kind of high morbidities and mortalities with the cancer treatment. Survival, it's again, I'll try to simplify this slides. It's complex slides. When you look at the green line, and that is the green vertical line, that is somewhere around 80% survival. Yes, most of the cancers we are doing very well, but look at the red line, that is around 40%. I put a line on that one. So particularly the brain and liver, esophagus, pancreas, and the lung cancers, stomach cancers, the survival is only 40%. That is the cancer we really need to focus on, improving the survival for those cases. Why do we need to diagnose cancer early? This is a very simple but effective slide. If you look at the top, lung cancer, if you diagnose this cancer at early stage, 6 out of 10 will survive. At late stage, 1 out of 10 will survive. Bowel, 9 out of 10 people will survive. If late stage, only 1 out of 10 will survive. For breast cancer, if you diagnose early, almost all of them will survive. But late stages, only 3 out of 10 will survive. Prostate, all of them will survive if you diagnose early, but on late stage, only 5 out of 10 people will survive. So it clearly says we need to diagnose cancer early. So how the cancer is being diagnosed in generally, you look at that, the GPs and primary care services are doing an amazing job. Almost 55 to 60% of them referred from the GP. And some of them urgent, some of them routine, and still 21% of the patients coming through emergency pathway, which is emergency hospital admissions. And that's, if you see that, the 21% of the patients, almost more than half of them advanced stage. So that's the area we need to target, why these patients being referred urgent instead of coming in a referred pathway. Instead of that, they're coming through accident emergency with emergency complications. If you look at the top one, the blue one, that's a national screening program. Only 6%, not all the cancers can be screened, but when they are under the screening program, almost 63% of them, they are detected at the early stage. So changing the way, the pathways, which is very important. So that's the government and the Center for Sustainable Cancer Delivery is doing an enormous job to streamline this process as well. So earlier and faster diagnosis plays a most fundamental role in the cancer control. Yeah. At this point of time, 42% of the cancers being diagnosed at stage 3 and stage 4 in Scotland. So our aim or vision to reduce that to 24% in next 10 years. So in that case, at least 5,000 people in the Scotland diagnosed at earlier stage. Are we doing better when compared to other countries with a similar standards? See, for example, we're not comparing with the USA or other countries. Similar countries like Australia and Canada, Norway, Denmark, and Iceland, these are all similar cancer work. So what we are trying to do here is That's okay. So what we are trying to do here is UK is in the bottom of the league. For example, still, if there is Australia, the lung cancer survival is somewhere around 45%. In UK, it's around 35%. We are catching up, but it's not at the rate of what other countries are catching up. There's a long debate what are the learning points from the other countries, but there are things we can certainly improve. So it's a difficult journey, but it again underpins prevention, early diagnosis, putting more focus on research, innovations, and collaborative working, leadership, policy changes, and so many other things are focusing more on less survivable cancers and improving survival as well. So what's our vision? So more cancers needs to be prevented, early cancers detection, and cancer survival needs to be improved, a strong public health and interventions.
Cool. Yeah, so I was noticed my voice was going away. My father's voice went away like this, and he went for an operation, but he left it for too long and ended up dying within 3 months. I came in after a few months and got treated with laser treatment and got home the same day every time. And apart from my voice, I've actually no symptoms of anything. So I've actually been quite lucky.
And you had a vocal cord cancer.
Yeah.
Yeah. It's just a simple story of the patient and his dad. Both of them had a laryngeal cancer. And one person had an early laryngeal cancer who had a laser treatment as a day case procedure, and other person, unfortunately, was not maybe treatable, I think. So, and the important thing is there is a fear about the cancer and getting help from the cancer. That all needs to change. And people should know how to access the cancer support. And also we need to minimize the unwarranted variation and across in terms of management of the cancer. So it's again telling the same thing. We need to aim for more people in the curative treatment, and also they need to have a timely access. Need to have optimized quality of life for each individuals, and also cancer treatment is a difficult journey. We need to make that pleasant as much as possible without much challenges in the patient's journey. So the main focus is, yes, we have limitations. The resources are limited. Already NHS is trained, and there are patients who hasn't got a cancer, but there are some disease which significantly going to impact their quality of life. Those needs to be given priorities as well. However, cancer has to be given given some more priority as well. And thing is, we have to develop some new models, working very collaboratively and recognizing what is the impact of the cancer, and that's very more important. When we talk about skilled workforce, there are some things we can do, some restructure the way we work and support people with a realistic medicine. When we talk about the cancer workforce, everyone is kind of heroes or heroines and superheroes or whatever the name or binary or whatever it is. But they can work effectively only if there is appropriate work environment and appropriate funding and appropriate number of staffs. Otherwise, they can't meet the demand, and that needs to be prioritized, and that's the most important thing. There's a simple example like new models and innovation. For example, I'm an ENT throat consultant, so I know what the innovations we can change. For example, is when there is a biopsy, when there's a lesion in the throat, there are ways to do the biopsies, like under gentle anesthetic, or like outpatient interventions, biopsy under local anesthetic. So this is a systematic review. I have written it with a Glasgow team. It clearly shows it's cost effective as well as it cuts down the 17 days in the patient's cancer journey. And it's equally effective and convenient for the patient as well. And it could be done on the same day or at least within few days. Certainly, Scottish Cancer Network and Centre for Sustainable Cancer Delivery, they implement a significant, I wouldn't say rules, it's management pathways, which is aiming for once for Scotland. It's aiming to minimize the variation in the standard we deliver to the cancer. And also it enhances the collaboration and networking with the surrounding boards to help in certain situations. Last but not least, the quality performance indicators, which is a kind of pain, but this is a kind of standard we need to follow and making sure we are on par with other boards as well as other countries. So recently, the lung optimal diagnostic pathway was released, and now the head and neck diagnostic pathway is in the process, and the RCDS is also is being implemented in certain centers. We're also looking for the options, and there's a new other innovative techniques. And as Tom said, there is a more diagnostic capacity. They work for pretty much every day, 12 hours. More than that, still we are struggling to kind of meet the targets. So our primary focus must continue to achieving outcomes, and important is shared decision making. Patient should be in the center of the care, and every information, including the treatments, prognosis, and other options of not having the treatment, and palliative medicine, and other form of discussion should be very open and should be transparent with the patient and also with the family. Because it's expensive, we really need to reduce the harm and the waste and make sure we deliver person-centered care with the maximum benefit. Yes, there are prevention strategies, for example, HPV vaccines and screening programs, and also more focus on harmful behavior reduction. For example, it says 40% of the cancers could be prevented by reduction of the harmful behaviors. Around 13,000 cancers could be prevented each year. And smoking is one of the commonest preventable cause that should be kind of reduced as well. Physical activity, yes, obesity is linked to nearly 2,000 cases of cancer, and physical activity also can reduce other cancers like breast, colon, endometrial, kidney, bladder, esophageal, and stomach cancers. And also there is a clear relationship between if there is a strong physical activity during, before, after the cancer treatment, it can reduce the anxiety, depression symptoms, and also improves the quality of life rehabilitation for a cancer treatment. Skin cancer is still the most commonest cancer in the world, and UV reduction, which is kind of should be the kind of main role to prevent melanomas, and more importance is about the public education and empowerment. And there's an interesting survey from the Cancer Research UK. It clearly said almost more than 7,000 patients with the cancer, almost 96% of the patients recognize they have at least one cancer signs and symptoms. And so, but what is stopping them getting access, I really don't know. And it's more importance is supporting the primary care. We have to work very collaboratively with the GPs and the primary care to support, because they play a heavy role for early detection of cancers and also prevention programs. Without their help, this cancer delivery or successful cancer program cannot run without that. And enhancing diagnostics. That's the key focus for this whole talk. Early diagnosis needs timely access to the most appropriate and effective diagnostic tests at both primary and secondary care. And clear evidence shows diagnostic imaging, endoscopy, PET-CT, and pathology will have a timely access with the results. You must have seen this one. I think my Gillian, our manager, gave the slides to me, and this is after this person's diagnosis. I think he's an Olympic champion, and he unfortunately diagnosed with advanced prostate cancer. That increases almost 672% in the prostate cancer symptoms, and also there is a almost 7-fold increase in the referrals. So there's a lot of media attention that kind of extrapolates into increased referral. And without all this data, especially if we have a data, we need to share it, being very open and transparent, so that it gives you a clear idea of planning. And of course, we need to focus on biomarkers, artificial intelligence, and multi-cancer detection tests. That pretty much comes under innovations and new models. And rehabilitations, again, which includes preparing the patients physically, mentally, psychologically, nutritionally, emotionally, and financially. That's very important. It helps cancer patients to get back on track after the successful treatment sooner. Newer like deliveries, for example, the robotic surgery we have seen this recently. They've done more than 1,000 cases. I'm very proud of that team, and that it literally provides a better cancer delivery. Of course, it's same for the radiotherapy as well as systemic anti-cancer therapy, and they also work very collaboratively using artificial intelligence, but still the pressure is very high. So, and the palliative care and the follow-ups, all similar. They all need to be standardized, and we need to follow the national standards. So NHS workforce is facing a significant pressure, and there is a clear reason for redesign and making sure the workforce is capable and make sure their mental health and well-being is also fine. And it's important treating the patient as an individual rather than the tumor or other things. This is a complex slide again, and it's what I said earlier. It's all there: preventing more cancers, earlier and faster diagnosis, best preparation, safe and realistic medicine, and sustainable workforce. And person-centered care, and making sure the cancer information and intelligence services on there. Yes, local and regional planning is needed. I think this is probably my kind of last slide, and coming to it's focusing more on individual, interpersonal support, organizational support, community, and national policies. So this is a simple slide. As I said earlier, this is about early cancer. So these patients usually have a transoral laser surgery, and that's it's like a 2 hours procedure. And
feel fine. Yes.
Is your voice?
It's still a wee bit gruff, but
it's fine.
It's fine. Yeah.
Okay.
Yes.
Your swallowing is all right.
Yes.
Okay. Suppose if the patient comes like 2 to 3 months later, and that cancer advances, become a large cancer, and this patient needs almost a total laryngectomy, speech rehabilitations, which normally takes 10 hours, probably 2 weeks hospital stay. 2 to 3 teams needs the rehabilitations, and sometimes they need more than one modality of treatment, including post-op adjuvant treatment. So it's a significant impact. Sometimes it takes up to years to get them rehabilitated. So that's a kind of state with advanced cancers. So in conclusion, cancer is a burden, and its incidence and urgent referrals are on the rise. It's a complex. Treating cancer is a complex problem. It costs a lot. Still, there are some variations in practice across, And we have to understand these challenges, and we have to focus on preventions, early detections, and we have to prioritize the cancer treatment and improve these things with innovative treatments and skilled, sustainable workforce. And that's making sure we are on par with international standards in terms of cancer delivery and survival. That's my talk. Thank you very much. My apologies once again. I don't know what happened. My I think computer crashed once I started sharing my slide. Thank you.
Can I ask a question to the team?
Yeah, please. Yeah.
So Jay, Tom, and Marie, thank you so much. I have put it in the chat function that, out of all the cancer specialties, we know that, some are struggling while some are achieving the targets and more. Unfortunately, it almost seems like a punishment of the specialties that are doing well, because its resources are now getting diverted to say that, oh, there is a priority more than cancer, which is on call. I just wonder what your take is, because it's almost as though a system is working, but you're diverting the resources, and then we will start failing in our targets, and then you start putting or making interventions to make the system succeed.
Tom, do you have an answer for that?
Thank you, Kalpana. Sorry, you have me at a disadvantage. I'm not aware of areas who are doing well against the targets, against the 62-day target. So I'm not aware of specialties that are having resources diverted because of good performance. I mean, I think our 62-day, and I'm talking about 62 days specifically, our surgery performance is reasonably good. I think because the way that the measure is structured, so the measure is structured from the conversation that typically the surgeon has with the patient to the surgery date, that we allow 31 days for that, and typically we're seeing an average of 10 days, 14 days for that bit. The part where we're challenged across all specialties, as far as I can see, is the front part of the pathway around access to outpatient clinics, access to diagnostic tests, repeat MDT discussions, etc. And I'm not sure that we're doing that particularly well in any specialty really. So I'm not quite sure what you're meaning there. Forgive me.
Yeah, sorry, Tom. Maybe I was not clear when I say that, yeah, at Gynae, our 31-day target is quite good. For 62-day, we are okay for most, except if patients have been referred via other specialty. But that's
Right.
the brain of the disease, because ovarian cancers do tend to come from respiratory or cardiac units or colorectal units. So that's where we struggle, because patients, it's the very nature of symptoms that it's so vague that they take a bit of time to reach us.
Yes.
But what I'm saying is, like, while we are trying our best to work on these processes, there has been a move to say that Tayside does value, in order of priority, it will be on call followed by cancer. So out of hours activity followed by cancer. And that puts cancer clinicians at a disadvantage, because you're only one person. You can't split into so many roles. And then you start thinking, oh, it is a lot of hard work already. What are we trying to achieve here? So I just wondered, if as a board, we are going to look to see that it is a hard specialty, the burnout in cancer, it's quite different compared to the other specialties, whether anything special, I'm not telling special treatment, at least we are not, I don't know how to put it. But I think from the top, it has to be recognized that the workload is very different for cancer compared to other specialties.
Yes.
Yeah, I think I got your point. It's important to recognize there is a ring-fenced workforce for cancer delivery. Otherwise, it's going to affect in long term. And also, The workforce for a cancer delivery has to be focused for the cancer delivery. For example, in simple terms, there may be 10 consultants in the department, but not all the 10 consultants may be delivering the cancer care. So we are trying to do like a DCAQ, more like a cancer subsite, whether that is the most appropriate way of dealing the cancer load. That's what I think we need to focus on. Whether if they take the cancer team members away from the cancer work, that's going to impinge on the performance. It may not be immediate, but in the long term. Yeah, I think there's a lot of background noise behind. Unfortunately, I'm with quite a few medical students.
Can I ask a question? So I'm not in service delivery, I'm very much within the research side of things. But it seems like, you know, you emphasize this need for earlier detection for better prognosis, but we've just completed a piece of work around people with a learning disability, and we see that they have a lower overall incidence of all types of cancer, but a much higher mortality rate probably because of a underdiagnosis at an earlier stage. So one of the things we found was that they're 3 or 4 times more likely to die of cancer of unknown primary origin, whatever that is. I can't remember, sorry. So yeah, there's lots of evidence to suggest that this patient population, these cancers just aren't getting picked up early. So I understand there's cancer screening programs in place, but is that enough? Because they don't participate in we know they don't participate in screening programs because there's not appropriate reasonable adjustments made often. So I understand no one's got any money, no one's got any resource, everyone's overstretched and whatnot, but it seems like the data, the numbers that you showed are quite concerning. And given the work that I see based on patient data from a national perspective, it seems that this group of people with a learning disability are particularly vulnerable and possibly being forgotten about.
Maybe it'd be helpful if I came here. Sorry, I'm Dr. Sal Peterson. I'm the primary care cancer lead, but I have a wider role with the Health and Social Care Partnership. And I think you're absolutely right. This is an issue that's really well recognised, not only for cancer, but also a lot through a lot of the other cancer, the other chronic diseases. We know that people with learning difficulties have more problems accessing care and don't get as good a care as the general population. One of the things that I didn't know if you knew was occurring is that there is the Health and Social Care Partnerships are looking at learning disability annual reviews, which have come from Scottish Government. And obviously the element of screening would be fundamental to that annual review. So certainly there is steps towards trying to rectify that situation, but I completely agree with you. It's a very vulnerable population, and one that, you know, we need to look out for equity.
Yeah, absolutely. The annual health checks are 2 years down the line, and of the 14 health boards, there's been pretty intermittent uptake of those, including one health board who's failed to even offer a single health check. So Tayside is doing okay, as I understand it, but I think there's lots to be done.
They've certainly started with our specialist teams in Perth and Kinross, which has been a real positive, getting those up and running. I think you're right. I think some of the sticking points is finance. and access, and who's going to do that, which is obviously the issue with a lot of them. But certainly I know that we've got a wide NHS Tayside team that are looking at this, because you're absolutely right, something they need that support.
Yeah, I think Kalpana has put something in the chat. The referrals have gone up, and we are running clinics overtly booked to meet the demand. Needed data to support us for job plans and extra, etc. That's true. That's true. Many of the clinics are overbooked, and that's also putting patients under risk, and also the clinicians under risk as well, unfortunately.
Hi, thank you. I just wanted to come in on a related point to what Laura and Sal were talking about in terms of demand. One of the things that we've been looking at is detection rate on the 62-day pathway. So in other words, the number of USC referrals, the number of cancers identified who started as a USC referral, which ties into the detect cancer early type discussion, but also into casting our net wider. So at the moment, well, the traditional view of demand is that we have to manage demand, and that's the kind of language that's used, is to manage demand. And typically what that means is, can we turn the tap off in some way? Can we control what's coming in, redirect it, or educate other care providers so that we reduce the flow into secondary care? That's usually what we mean when we say manage demand in secondary care. But the data, and we've got some articles which we can reference and share after, shows that rather than trying to manage demand down, when you manage demand up, when you cast the net wider and encourage referrals, as many referrals as possible, through promoting screening programs or encouraging more referrals from primary care, the detection rate on the 62-day pathway goes up, which means more patients are being diagnosed at early stage, and therefore survival is better. So the USC referral rate has doubled in the last 7 years, and our response to that, the typical knee-jerk response to that was, well, what are we going to do about that? How do we reduce that? How are we going to manage that? Actually, what we're saying, and what the evidence is showing, that we not only need to encourage that, we need to get it more. We need to get that demand up more to improve survival. And the correlation between high referral rates and survival is very clear. And if the group that you're talking about is one that's poorly served, then that's ties into that kind of thinking of widening the net